All right, we got looks like one more. All right. Good morning or good afternoon, everybody. Just so everyone knows, we are recording at the moment. So any questions that are specific to your child or any other child, let's save those till the end after we can stop the recording because the recording is going to be posted on the Life website. Tammy is going to be monitoring the chat in the lobby for me, so if other people join, we'll just get them in. I think we have another one. Okay, third disclaimer, we are recording now. We're going to save all child-specific questions till the end. Any general questions, we'll just get them throughout. You can also drop them in the chat, and Tammy will be monitoring that. Okay, so we're going to talk about common sleep issues for children, specifically children with disabilities. We're going to cover why sleep is important, common sleep challenges that we find, a thing called sleep hygiene, which we'll go over in a little while, and then other general sleep strategies. Okay, so sleep's important for a lot of issues, or for a lot of reasons, excuse me. Sleep issues affect not only the individual who struggles with the sleep, but also the entire family. So it can pose interference with learning, things like irritability, distractibility, fatigue. All of those things inhibit learning, both in school settings and at home. Also, that can create safety concerns. Children who are lacking sleep are more likely to engage in problem behaviors like hitting each other, hitting themselves, things like that. Health concerns are a big issue, right? Children who are struggling with sleep are more likely to develop obesity, more likely to develop emotional behavioral issues, more likely to suffer from anxiety and depression, or lack of sleep has a lot of the same effects that it would have on our kids, also transfers over to our guardians. Can also create a strain on relationships, both, whether it's your significant other or your spouse, or between you and your child. It can kind of strain all of those relationships within the family. So we want to try to figure out how to reduce that. Right? We don't want any of these things to be happening in our lives or in the lives of the kids that we care about. Okay. So one thing to know as we kind of get started, amongst our neurodiverse population, right, children with developmental disabilities, the rate of them that suffer with sleep problems is a lot higher than with typically developing children, right? Kids that might be called neurotypical. Typically, only 20 to 30% of them struggle with sleep issues, whereas when we talk about our populations with some kind of disability, it skyrockets up to 50 to 80%. So that's a lot. And I just want to kind of put that into there. Excuse me, I want to put that in there just as a disclaimer for any parents or families who are struggling with sleep. You're not alone. This is not something that only your family deals with. So if you're feeling that way, I just want to let you know that you're not alone. Okay. So we have 6 of our most common sleep challenges. These are delayed sleep onset, night waking, early morning waking, bedtime resistance, sleep dependencies, and unwanted co-sleep. And it's not uncommon for multiple of these to happen at the same time. So we're going to break down kind of what each of these are, and then later in the presentation we'll break down what to do about each one, because your approach is going to be slightly different depending on which problem or problems you're having. So the first one, delayed sleep onset, is just when the child does not fall asleep after being put to bed. So they might remain awake and play quietly in bed. They might call out to caregivers. They might attempt to exit the bedroom. All of those things fall under that category of delayed sleep onset, right? You do your nighttime routine, you put your child down to bed, and then they just don't fall asleep. Bedtime resistance is very similar, but it tends to refer more to those escalated behaviors that might occur when the caregiver attempts to put the child to bed. Things like crying, screaming, environmental disruptions, tantrums, aggression, self-injury, all of those things would fall under bedtime resistance. So it's almost, I like to think of it almost as a subcategory of delayed sleep onset. Usually when you have bedtime resistance, that's also causing delayed sleep onset, but not all delayed sleep onset is because of bedtime resistance. The next one is night waking. This is pretty much what it sounds like. Anytime the child is waking up during the night, especially after they fall asleep initially and then they wake up at different intervals. Could be once, could be twice, could be dozens of times. Anytime they're waking up in the middle of the night, that's what we refer to as night waking. Early morning waking is very similar. It just refers to when the child wakes up during the night and then doesn't go back to sleep. Typically happens in the early morning, uh, as the name indicates. Sometime around 2 to 4 a.m. the child wakes up and they're just up for the day. Sometimes, a lot of times, that can happen with night waking. Maybe the child wakes up. You put them to bed at 10, they wake up at 11, they wake up at 12, they wake up at 2, and then they're up for the rest of the day. Not always, but those tend to go together, those two. And then the last two, sleep dependencies and unwanted co-sleep. So sleep dependencies is anytime the child is unable to fall asleep without access to a particular thing. That could be music, could be some sort of toy, could be watching videos. I know people who can't fall asleep unless the TV is on, right? Those are sleep dependencies. Unwanted co-sleep can almost be thought of as a type of sleep dependency specific to the parent or the caregiver. So this is when the child is unable to fall asleep without sleeping in the same bed as the parent or the caregiver. Anybody have any questions so far? Perfect. Okay, we're going to jump ahead. Before we jump into actually how to treat these different issues, I just want to kind of give a disclaimer. If you suspect there might be medical or biological factors impeding your child's sleep, please, please, please seek out medical help before trying behavioral approaches. If there is a medical issue happening that's impacting the sleep, the behavioral approaches are not going to be effective. It's going to be like trying to put a band-aid on a wound that needs stitches. It's just not going to work. It's not going to be beneficial. So there are also some medications that help to increase sleep readiness or drowsiness. If you think that's something that might be helpful for your child, again, just seek out your pediatrician, maybe a developmental psychologist, some kind of medical professional who can help you with that. That's going to be outside of the scope of this training. This presentation is just focused on behavioral strategies. Okay. The first thing we're going to talk about in terms of actually treating those 6 issues we talked about is something called sleep hygiene. So sleep hygiene just refers to a set of general strategies and tips for developing a healthy bedtime routine. Uh, these are often enough to resolve sleep issues on their own, but not always. So if these sleep hygiene strategies don't solve the issue, it's usually a good idea to go into some of the more intense behavioral approaches that we're going to talk about. But these are usually the best starting place for any sleep related intervention. You want to start with sleep hygiene, and then if that doesn't work, move on to more intense things. Sleep hygiene is also, these strategies are things that if you do move on to more intense strategies, you still bring the sleep hygiene along with you. It's something that's going to be important for pretty much any kind of sleep intervention you're going to try to do with your child. So the first set of 4 on the slide, we want to maintain consistent sleep and wake times. If those sleep and wake times are changing each day, it's really difficult for the child to develop any kind of bedtime routine or circadian rhythm that's going to be important for them to sleep. Once it's age appropriate, we want to avoid napping. So for our little children, anywhere 2 to 5-ish, naps are generally okay. After that, you want to try to avoid them. We want to try to help our children develop an age appropriate circadian rhythm. And again, if you have questions about what that might be for your child, I'd encourage you to talk to your pediatrician. They'll be able to kind of help sort out those details. We want to try to avoid caffeine 6 hours prior to bedtime or more if you can. I think that one's relatively self-explanatory, right? Caffeine makes you not tired. We want our children to be tired so they can go to sleep. And then the last one on this slide, we want to try to reserve the bed for sleeping only. If this kind of goes for all people, but especially for our children and our populations, if the bed becomes a place to play and a place to watch videos and a place where fun happens, then they're less likely to fall asleep at night because you put them down in bed and they say, okay, perfect. Now I'm ready to play and have fun and watch videos. So what we want to do is create an association that says, nope, play is in some other location. And once we're in bed, it's time for laying down. It's time for closing our eyes. It's time for sleeping. These are some guidelines just from the Mayo Clinic. by age of how often, how long the child should be sleeping and whether naps should be included or not. Again, I'd encourage you to talk to maybe your pediatrician or a developmental psychologist about breaking this down specifically for your child. Most parents have a pretty good idea of whether their child should be napping or not, but it's never a bad idea for a medical professional to weigh in on those kinds of things. This will also help determine what those bedtimes and wake times should be. Like it said on the last slide, we want to develop some kind of stable bedtime and wake time. So knowing how long roughly your child should be sleeping each night can help to determine that. Sometimes sleep issues can be solved by just realizing, oh, my child doesn't need to sleep for 12 hours anymore. They need to sleep maybe for 8 hours. So let's kick their bedtime back a little bit and their wake time up a little bit, and then they start sleeping fine at night. So sometimes that's enough to solve the issues. Another thing we want to think about as part of our sleep hygiene is the bedroom condition. Are there any distractions in the bedroom? That's going to be one of the biggest things that prevents sleep behaviors, right? A phrase I like when I'm talking about the bedroom is dark, cool, and quiet. Those are the three things we want to hit. We want the bedroom to be dark, only indirect light. My child sleeps with blackout curtains, and that really helps us because our neighbors have really bright lights on the side of their house, and they shine right into that window. Cool, we want the environment to be comfortable, not cold, but also not warm, not hot. Most studies have shown that cool enough for a light blanket is usually your ideal temperature. That varies a little bit depending on the person, but somewhere in that range. We don't want it to be hot. We also want the bedroom to be quiet. We want to avoid unpredictable or loud noises. Usually if there's some kind of white noise that's constant and steady and is not changing, that's fine. So if you live in a noisier area or you have loud neighbors, something like that, white noise can definitely be something to consider. So either white noise or quiet would be best. The last thing on this slide, we want to avoid preferred items, especially if they're distracting for the child. Anything like electronics or toys, things like that. We want to make sure they're not visible and they're not accessible. We don't want the child to be put to bed and then start getting out toys or having toys in their bed that they begin playing with that compete with those sleep behaviors. We want them to lay in bed and close their eyes and go to sleep, right? There is a difference here between comfort items that can help with calming down and sleeping, like maybe a stuffed animal or a special blanket, versus those toys and distractors. And that kind of varies by the kid. For some kids, those stuffed animals can be the distractors that they play with. Other kids find it helpful to have a stuffed animal that they can maybe hug and snuggle with. So that one, you guys know your kids, so kind of judge it on a case-by-case basis and try to figure out, is this item helping my child fall asleep or is it distracting them from falling asleep? If it's distracting, we're going to want to look at removing it. Okay, the next thing for our sleep hygiene is looking at our nighttime routine. We want to try to find routines that are short, predictable, and sustainable. I really like that phrase, similar to the bedroom, dark, cool, and quiet. Routine should be short, predictable, and sustainable. We don't want anything overstimulating. We want something quiet and relaxing, but still enjoyable. Something to consider here, we want to try to build in to our evening those stimulating and enjoyable activities, but we want to do them well before bedtime. We don't want at bedtime the child to be craving those things. We want to do them before bedtime so they get their fill, and then as bedtime gets closer, start to build in more of those relaxing activities. Even with the routine itself, it's okay to start with something that's maybe more stimulating and then through the different activities slowly calm things down. Other things we want to consider here is using the same sleep space each night. This again goes back to making that bed something that when the child gets into bed, it signals in their mind, okay, it's time for sleep. If snacks are given, we want to try to avoid sugary treats, also avoiding caffeine here. Anything that's going to make the child jittery or energetic, we want to try to avoid. So the routine I use for my child, we go into his room, say it's time for bed. We go into his room. We turn the sound machine on. That's the first thing we do. The lights are still on when we turn the sound machine on. Then I help him change into his pajamas. Maybe we do some tickles. So something that's enjoyable, maybe more on the stimulating end. And then as the routine progresses, we're going to kind of slowly go to more relaxing activities. So after pajamas and tickles, we'll sit, he'll sit on my lap, we'll read a book while we rock, and he'll drink some milk. Then we'll go brush his teeth and turn off all the lights. Then I tuck him into bed, we do goodnight kisses, and then I say goodnight and the parent leaves the room. So as the routine progresses, we're getting more and more calm. The environments are getting darker. The sound machine is on. All of these things are signaling in the child's mind, okay, it's time for sleep soon. The other thing for sleep routines, they don't need to be super long. We want something maybe 15 minutes, maybe 30 minutes max, something that can be, again, sustainable. So if it's too long, if your routine becomes an hour and a half, that's not going to be sustainable to do every night. So we want to keep them nice and short, predictable, and sustainable. Okay. Recap on our sleep hygiene. We're going to set a sleep schedule based on our child's wake times and bedtimes, including any naps. We want to make sure we have our bedroom conditions are dark, cool, and quiet, and our nighttime routine is short, predictable, and sustainable. Any questions so far? Okay, amazing. So again, sleep hygiene is where we start. If you're not already using these strategies, I'd encourage you to try them before we try anything else. A lot of times, just sleep hygiene alone can solve those sleep issues. But if it doesn't, we got to break down why each sleep issue is happening based on the sleep issue that we're seeing. There's not going to be a one size fits all solution. After we've tried sleep hygiene, those don't work, then we have to break it down by issue. So the first one's delayed sleep onset and bedtime resistance. I lump these together because, again, bedtime resistance is just more escalated behaviors that are causing that delayed sleep onset. So for this one, we're going to try to figure out why are these behaviors happening? Why are the interference behaviors happening? That doesn't just have to be the screaming, the crying, the tantrums. This can also be, why are the play behaviors happening? Why are the call outs happening, right? This could be the child, you lay the child to bed, you leave the room and they're saying, Mom, 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 I need you, Mom. This could be the child gets out of bed and says, I need a drink of water. I need to use the bathroom. I need to do that. Those all kind of fall under the delayed sleep onset, and we need to figure out why are those behaviors happening. So the first reason they could happen is attention or interaction with parents, caregivers, or other siblings. If this seems like the reason that your child is struggling with delayed sleep onset or bedtime resistance, the things we want to try are providing high quality attention throughout the evening and especially during that bedtime routine. If the child has had lots of attention throughout the night, it decreases the motivation to want that attention right at bedtime. If the child is engaging in any kind of sleep interfering behaviors after the bed goodnight and the parent leaves the room, we want to keep the quality of attention very low. So after you say goodnight, put them in bed, you leave, even if they're engaging in behaviors that require you to give some form of attention for safety, we want to keep the quality of that attention very low. We want there to be a very big difference between the type of attention they're receiving before bedtime and after bedtime. We always want to consider safety. If the child is doing something dangerous, keep them safe. That's always the priority. But when you do so, provide the minimum amount of attention necessary to do so. There's also a strategy called a pop-in intervention that may be useful for children who are struggling with falling asleep due to wanting parental attention. The main idea here would be the parent leaves the room, they say goodnight, they leave, they wait, and then if the child is quiet and is engaging in those pre-sleep behaviors that we want, laying down, potentially closing their eyes, those kinds of things, the parent might come back in, step into the room, say, oh, hold on, I forgot, and then say something to the child, give them some form of attention, and then leave the room again. Over time, increasing the amount of time between those pop-ins. That type of intervention can be a little bit more nuanced, so I'd encourage you to talk to an ABA professional to help create a specific plan if you think that'd be something that's useful for your child. I just wanted to mention that it is a thing that is in the ABA literature so that you are aware that it exists. Okay, to the next one, for access to toys, food, drinks, things like that. If you think this is the reason that your child is struggling with delayed sleep onset, we're going to have some similar strategies, some a little bit different. We want to provide access to those items throughout the night, throughout the evening, especially during the nighttime routine. Again, having access to those items before bed lowers the motivation for getting them when it's bedtime. Once the child has bid goodnight, I would not allow them to access those items. We want them to learn that, hey, once it's bedtime, once I tell you goodnight and lay you down, those items are no longer available, no matter what you do. Some children may benefit from a form of pass system for this, where they're allowed 1 or 2 passes out of bed to go get an item or get a drink. Again, similar to the pop-ins, I'd suggest talking to an ABA professional to help create a specific plan for your child if you think that would be useful. The big takeaway here is once they're bid goodnight, those items are not available, so that then they learn, even if they're engaging in all of these sleep interfering behaviors, those items still do not become available. Okay, the next one, escape from the bedroom. What do we do if the child's not really interested in attention? They don't seem to want any particular thing. They just want to get out of the bedroom. Welcome. So for this one, we want to try to make the bedroom a good place where the child wants to be. So we want to try to do as much of the nighttime routine in the room, making that nighttime routine enjoyable. And then if the child gets out of bed and leaves the room, we want to gently guide them back to bed and then leave the room again. Again, keeping that attention very low quality so that this doesn't become a game. We want to just, it's bedtime, bring them back to bed, lay them back down and leave the room. This will over time teach the child, even if they're leaving the room, they just get brought right back to bed. There's nothing fun about leaving the room, and the room is not a bad place to be. That pass system we talked about for wanting to access toys, food, and drink might also be useful for children who are just looking to get out of their room. But again, I'd encourage you to talk to an ABA professional to maybe come up with a more specific plan if you think that would be helpful for your child. Okay, the last one, automatic or sensory. This tends to be one of the more difficult ones where just staying up is fun for the child and that's why they're doing it. This could be a sign that your child's not tired. So we talked a little bit earlier about those bedtime, setting that sleep schedule for those bedtimes and wake times. If your child's just not falling asleep and it doesn't seem like they're trying to escape the bedroom, they're not trying to access toys, food, or drink, they're not trying to get attention, maybe they're just laying there awake, talking to themselves or something like that, but they stay there for hours and they just don't fall asleep, we might want to consider changing either their bedtime or their wake time to see if maybe they're just not tired when you're putting them to bed. It could also be that maybe we add some additional physical activity into their daytime routine. Maybe we go for a walk or we play some kind of sport or we do something that helps to build more of that fatigue so that they are ready to go to sleep when they're supposed to go to sleep. For this one, there's also a strategy that we can use called fated bedtime. This one, again, I would encourage you to talk to an ABA professional. But basically, you just manipulate the bedtimes in different ways until we find one that sticks and then slowly change it to where we want it to be to get to the desired bedtime. Okay, one thing to note for this, sometimes small sensory seeking behaviors can actually help the child calm themselves down. So we don't need to stop all sleep interfering behaviors. We only need to worry about these sensory seeking behaviors if they're actually distracting the child from sleep. So for example, my son sits and he twirls his hair and he talks to himself. He goes, ah, yeah, 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 ah, yeah, 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 while twirling his hair. Totally fine. That helps him to calm down and fall asleep. Now, if he were standing up and jumping on the bed, I might go in and just gently lay him back down and say, it's bedtime, and then leave the room again. We want to allow behaviors and self-soothing behaviors that are going to help the child fall asleep and try to prevent behaviors that are going to make the child more amped up and less likely to fall asleep. Okay. Any questions about delayed sleep onset and bedtime resistance and how we might treat those two? One thing to note too, if you are struggling to determine which self-soothing, maybe stimming or sensory-seeking behaviors are okay to allow at bedtime and which are not, an OT might be a good resource to help with that, or an ABA professional. So maybe sit down with one of them and then you can really dig into the specifics for your child. Just want to put that out there. Okay, our next slide is going to talk about sleep dependencies and unwanted co-sleep. What do we do if we're struggling with this? So the goal here should be to create positive sleep dependencies that can then replace the unwanted sleep dependencies that are creating issues. So we want the child to be dependent on a pillow, maybe a blanket, some kind of stuffed animal, or a sound machine, and we don't want them to be dependent on the TV or the radio or the presence of a parent or caregiver or physical patting or rocking, things like that that may be difficult to facilitate. As I mentioned earlier, the unwanted co-sleep gets lumped in here because it can be thought of almost as a type of sleep dependency. So the way we fade in and replace those sleep dependencies with wanted sleep dependencies is going to be to slowly reduce the presence of the unwanted dependency across multiple nights, while at the same time adding the presence of the wanted dependency. So this is going to take a lot of patience, a lot of consistency, but if we keep up with it over a period of weeks, the child can slowly become dependent on the things that are easier to build into the routine and not dependent on those things that we don't want them to be dependent on. We want to avoid creating sleep dependencies for things that the child will miss if they wake up in the middle of the night. So children who might fall asleep to listening to music, if that music is then turned off once they fall asleep, if they wake up during the night, it can be very difficult for them to fall back asleep. We also want to find items or activities that can travel easily in case the child is ever sleeping away from home. So we try to avoid things like that TV or the presence of a specific person that might not always be available for the child. They might work at home, but if you ever go anywhere or if the child ever has to sleep away from you, that can really disrupt their sleep if they're reliant on those things. The other thing we want to try to avoid here are transitions, such as letting them fall asleep in one place and then moving them to their bed. So some families, right, maybe the child falls asleep in mom and dad's bed while cuddling with mom and then is moved to their bed. That can work in the short term, but it builds in those unwanted sleep dependencies, and it can create barriers for the child ever being able to fall asleep in their own bed. Similarly, if mom and dad's bed is for some reason not available, or if mom and dad are not available for some reason, maybe they're staying with a family member, then the child's going to have a really hard time falling asleep on their own. Any questions about creating those wanted sleep dependencies, reducing unwanted co-sleep, anything of that nature? Okay, if you do for some reason need to transition your child from one location to another, it's better to do it while they're drowsy rather than when they're all the way asleep. We want the child to learn to fall fully asleep in their own bed. So for the example of the routine we gave earlier, if rocking and reading a book was the last step before putting them in bed, it's totally okay for them to be drowsy while reading a book, but we don't want them to fall asleep while reading that book and rocking. We'd like to get them drowsy and then transition them to bed so they can learn to fall asleep in bed. All right. Our last sleep issue, night waking and early morning waking. Again, these get lumped together because they're pretty similar. If the child wakes during the night, we want to make sure that the environment is conducive for them to fall back asleep. So this ties in with our sleep dependencies we just talked about. Oh my goodness, excuse me. This ties into the sleep dependencies we just talked about. We want to make sure anything that's present when the child falls asleep that's helping them to fall asleep is also going to be present if they were to wake up during the night. We want to consider testing different bedtimes if they're struggling with night waking or early morning waking. Like I said, for the delayed sleep onset, if the child is struggling with this, it might be an instance of they wake up because their body's not super tired. Maybe we need to build in more physical activity during the day, or maybe we need to adjust their bedtime or their wake time so that they are more fatigued at night and they can sleep through the night. If the child wakes and leaves the room in the middle of the night or early morning, similar to that delayed sleep onset, we just want to guide them back to the bed and then leave. I would recommend not guiding them back to bed and then laying with them or helping them fall back asleep. We want them to learn to stay in the room and to fall back asleep on their own if they do wake up at night. If you can figure out why the child is waking up, we can try to treat based on that, similar to the delayed sleep onset and the bedtime resistance. If it seems like they're just waking up for no reason, then some of these other strategies might work. We want the darkness in the room, like we talked about for setting that environment, to signal that it's time to stay asleep if they were to wake up. So sometimes when it's time for the child to wake up, opening a window or turning on the light when it's time for them to wake up can help teach them that, hey, when lights are on, it's time to be awake. When the lights are off, it's time to stay in bed and be asleep. There's also alarm clocks that can gradually brighten when it's time to wake up. Those can help to teach that same kind of thing if, a window or something like that is inconvenient or isn't a good fit. Okay. This is another time where that faded bedtime intervention that we talked about for the delayed sleep onset might be helpful. Just manipulating those bedtimes until we can find a time where the child is falling asleep and staying asleep, and then slowly changing it to be where we want it to be. Again, I encourage you to talk to an ABA professional. They can help provide guidance for your specific child. But that also could be a good strategy here. Okay, last thing we're going to talk about, because this is an ABA presentation, I have to talk about our measurement. ABA is all about measurement because it helps us to accurately identify why the issue might be happening and whether our intervention is actually making a difference or not. It also gives us the opportunity to test different interventions. If we try one thing and we're like, maybe it kind of helped, but I'm not really sure, and then we try something else and we don't have data, it's hard to compare which one actually had a bigger effect. Unless the effect is super drastic, obviously, then you can tell just by quality of life. But if it's between two effects and they're relatively minor, having some kind of measurement system is going to help figure out which one we should go with long term, which one had a better effect. It also reduces the chance that human error or forgetfulness is going to impact our judgment when trying to decide whether an intervention had an effect or not. Sometimes you might try something and it helps the child to sleep maybe 30 minutes earlier, and that's not a huge effect, so you don't really think about it. But if we have some kind of measurement system and we can chart that out, then we can see, okay, it is having an effect. Maybe we keep going, or maybe we double down on this intervention rather than just abandoning it. ABA professionals can help provide assessment tools and help interpret results. I have 2 copies that we can send out along with this training of different sleep assessments. But I would encourage you, if you do want to fill one out, talk to an ABA professional. They can kind of help interpret what you're seeing after you fill it out. The measurement system I would recommend for sleep issues is something called a sleep diary. This is usually the most simple type of measurement system. It's not the only type, but it's typically the most simple, the easiest for parents to implement. It doesn't have to be an actual diary. It could be just pieces of paper. But basically, you want to record events that happen at night, whether it's, hey, at 6:30 we started our nighttime routine. At 7, the child was put into bed. At 7:10, they actually fell asleep. At 9 o'clock, they woke up, etc. Things like that throughout the night. Any behaviors that occurred, anything that was out of the ordinary. Hey, bedtime routine started at 6:30 like normal, but the child went to a birthday party today and they might be especially tired. So maybe that's why they fell asleep today and didn't fall asleep on previous days. Some things like that might affect why the child is either sleeping or not sleeping. Again, this just helps you to remember when you're trying to assess, okay, it's been 3 weeks of this intervention. How much of a difference have we had? Well, last night was really rough, so it feels like we haven't really made any progress, but the previous 5 nights were actually really good. So it kind of helps to take some of those emotions out of it, especially when we as parents or caregivers might be tired and fatigued from our child's sleep issues. So just having things written down is always helpful. I would recommend beginning some kind of measurement system 1 to 2 weeks before starting an intervention. That way, once the intervention starts, you can look back and tell whether it's actually having an impact or not. This is, again, similar. We don't want to have our intervention and measuring for 3 weeks and then look back and say, okay, is this actually different than what we were seeing before? If it's a drastic difference, you'll probably be able to tell just as a parent. But if it's not, if it's only a small difference, it might still be impactful, but you might be more prone to forget about those things or miss those kinds of things if we don't have some kind of measurement system. Okay, kind of wrapping things up here. The things we talked about, sleep hygiene, those are going to be determining a sleep schedule, making sure the bedroom is dark, cool, and quiet, and creating a short, predictable, and sustainable nighttime routine for your child. If those things don't work, we're going to want to try some type of function-based intervention, meaning that we want to figure out what type of sleep issue our child is having and why that issue is happening and try to address it based on that. And then lastly, we want to have some form of assessment or measurement system to determine whether progress is actually being made or not. Does anybody have any questions before we end the recording? Okay, I'm going to go ahead and stop the recording, and then if anyone has anything more specific to their child, we can get to that.
Josh, I had a question. What about if a child is a potential candidate for sleep apnea?
Yeah, great question, Miss Margaret. So that would go under more of those medical conditions. If you think your child is struggling with sleep apnea or any other kind of biological or medical factor, I would encourage you to get with some kind of medical professional who might specialize in those things prior to trying any of these behavioral interventions. If your child's struggling with sleep apnea, we can manipulate the bedtime routines and the bedroom conditions and all of those things, and it might not even have a difference, might not even make a difference. So we always want to rule out medical and biological factors first.
Yeah, just to piggyback on that, I don't know if you guys can hear me, but in terms of some medical interventions, some really common ones you see in this population outside of sleep apnea is you see a lot of enlarged adenoids and tonsils that create some barriers to breathing. So if you notice that your child tends to be a mouth breather, you might need to look at that. If you notice that your child snores pretty heavily or that they're very restless when they are sleeping, those are all signs that they might have enlarged tonsils or adenoids. Another one is if your child is prone to seizure activity. So seizures typically happen with individuals while they're sleeping, and we don't catch it. So it'll also appear as if your child is restless, but you'll need a medical diagnosis to rule that out because no amount of sound machines or dark rooms are going to fix that. So we do encourage medical first, then behavioral.
Right. Yes. If your child is experiencing night waking, maybe just check to make sure they're not having seizures that are waking them up or something like that. Because then, like Tammy said, we can do behavioral interventions till we're blue in the face. But if it's seizure related or medical related, we're not going to have any success.
Josh,
Okay.
I have one more question, if I may.
Of course.
What about for these parents, or how would you direct these parents, on how to get started when you're hearing, situations where the kids are getting up in the middle of the night, they're coming in and, causing bodily harm to the parents or to their siblings, or we hear about parents who are having to sleep on the floor in the kids' rooms, to ensure that, they're safe and that they're not getting up and wandering the house. And, what practical advice could you give these families who, are in extreme situations of sleep deprivation, just obviously for the kiddos, but also for them, and the impact that could have on the family as a whole?
Yeah, that's definitely something to consider. Thanks for bringing that up. If you're in crisis mode, that might not be the best time to implement sleep strategies. We want to get you out of crisis mode first. So there are different resources that we can provide, things such as bed alarms, where it notifies you or sets off a quiet alarm when the child gets out of bed so that the parent can then wake up and make sure the child is safe. Similar things, you could put some kind of alarm system on their door, so if they leave the bedroom, you're notified or you're awoken. There's also, I've heard of families who have utilized respite providers for children who maybe aren't super self-injurious or super aggressive, but they'll just get up and wander the house and get into things. So maybe a respite provider can come from certain hours of the night and just stay in the home, making sure that if the child gets up, either the respite provider can wake the parents or the respite provider can stay with the child to make sure the child is safe so that the parents can sleep and get that what's necessary for them to function, right? We want to make sure as parents and caregivers that we're taking care of ourselves so that we can care for our families. Now, once you've done those things, if you feel like you're in a place where you're not in crisis, but we really got to figure out some of these sleep issues, And there are those bedtime resistance behaviors happening, whether it's in the middle of the night or at bedtime. I would encourage you to try to assess why the behavior is happening. Is it related to that attention or that interaction with people? Is it more related to access to toys or food or drink? Is it more escape from the bedroom? Is it none of those three? And so maybe it's something where the child, maybe there's some kind of sensory component or something like that. And then I would use those strategies that we talked about for the bedtime resistance. Again, sometimes these sleep issues can coincide with each other. So sometimes it's night waking plus then bedtime resistance and delayed sleep onset when you try to put them back to bed after they wake up in the middle of the night. And so then you can take almost the strategies from the night waking and the strategies from the delayed sleep onset and kind of put them together and see if that helps. So it's never a bad thing if your child is struggling with more than one of these sleep challenges to take those interventions we talked about and mix and match in a way that works for your family and your child. Having an ABA provider in your corner, they can always help with some of those things during parent training meetings and try to develop some kind of intervention that might work well for your specific child. But this presentation is just meant to kind of give you general strategies that you can try and you can tinker with and see if those help. If those don't, I would encourage you to seek out a medical professional who specializes in this, or an ABA professional who has some background in treating with sleep, and maybe get something more individualized. But for most children, these general strategies will at least help, even if they don't fully solve the issues.